My name is Neha Mehta Shah from Washington University in St. Louis, and it's my pleasure to present for you today updates in lymphoma and what have we learned at ASH 2020. And this is meant to be an overview. There's certainly lots of exciting things that occurred at ASH in heme malignancies and in lymphoma specifically, but to give you some of my favorites. These are my disclosures. So to start with, some updates on CAR T-cells and bispecific antibodies, and this was certainly a large portion of the updates in ASH in both indolent and large cell lymphomas. So relapsed refractory diffuse large B-cell lymphoma remains a common problem. This is the most common lymphoma that we see, and up to 20 to 60% of patients with diffuse large B-cell lymphoma will relapse after their frontline therapy, and 15% are refractory to their frontline therapy. And in the patients who are refractory, only 30% are disease-free and alive at the 3 years. And so this is a substantial problem that we have to overcome as lymphoma specialists. For patients who are chemosensitive to their salvage therapy, the standard of care has been an autologous stem cell transplant and in that setting. In 2017, there was the approval of CAR T-cells after 2 lines of therapy, leading to a 2-year progression-free survival of 30 to 40%. And as a result of this, or starting in 2018, we've seen a decrease in the number of auto transplants done. So the CAR T-cells for diffuse large B-cell lymphoma, there are now 3 agents approved, which I'll refer to by their trade names out of simplicity: Yescarta, Kymriah, and the Juno or JCAR line. And each of them is approved for after 2 lines of therapy, including for patients who have transformed follicular lymphoma. The response rates have ranged from 83 to 73 or 53%, but remarkably at 6 months, about 30 to 40% of patients remain in complete remission. And for patients who achieve complete remission and remain in remission at 6 months, their survival is very good at 30 to 40% long-term. So when do we consider CAR T-cells for patients with diffuse large B-cell lymphoma? Patients with diffuse large B-cell lymphoma will get their first-line chemotherapy, often anthracycline-based. When they have relapsed disease, we give them salvage therapy, most often combination chemotherapy. And if they achieve a complete remission to their salvage, they should go on to an autologous transplant. And for patients who are refractory to their salvage therapy, we often recommend CAR T-cells. And for patients in partial remission, there's some debate on what to do, which we'll talk about a little bit later, but this was a schema that was pulled from a How I Treat paper published by Dr. Chow and colleagues. So Zuma 12 was a study that was presented this year at ASH of using CAR T-cells earlier in high-risk patients. So what they did was they looked at patients who are at very high risk of having primary refractory disease or relapse disease. So patients with a high IPI with large B-cell lymphoma, or patients who had double hit diffuse large B-cell lymphoma, those who had rearrangements of MYC and BCL2 or BCL6 on FISH. Those patients received 2 cycles of anthracycline-based therapy. And then if they had lack of a complete remission, they went on to bridging therapy potentially, and then CAR T-cells. And the primary endpoint was complete remission by Lugano. 27 patients were treated in this study who received CAR T-cells as essentially their first salvage in the setting of their initial therapy. 85% of these patients achieved a remission, including 74% who achieved a complete remission. And interestingly, there are patients who had initially a PR or stable disease who converted to complete remission after their initial assessment. The median duration of response was 9.5 months because of the short follow-up. The median follow-up on the study has only been 9.3 months. And of the patients who had responses, 70% of them are ongoing, which is pretty interesting and remarkable. One of the things that Dr. Nilapu and colleagues had noted was that they looked for the amount of CAR T cells and their level of expansion, and this looked to be more robust compared to in patients where CAR T cells were employed earlier on than in data from CAR T cells in the salvage setting. So more to come on that as well. Can CAR T cells be used as first salvage? This is the subject of two international studies. One is ZUMA-7, and the other one is called TRANSFORM, where patients who have relapsed refractory diffuse large B-cell lymphoma go on to being randomized for either CAR T cells or salvage therapy with an auto transplant. And these studies are the first studies are expected to be resulted in 2022, so we look forward to that next year. One of the interesting papers or retrospective papers that was discussed at ASCO this past year was looking at the CIBMTR registry of patients who underwent auto transplants and pulling out the patients who achieved a PET partial remission. And those were at the determined by the treating physician. So there wasn't a centralized method of PET methodology in this retrospective analysis. But when they looked at the 249 patients who did undergo a salvage auto transplant after salvage therapy and had achieved a PR to salvage therapy, 40% of those patients remained progression-free at 5 years. And I think for that reason, auto transplants for patients who have complete remissions or partial remissions to their salvage chemotherapy currently remains an option. And CAR T cells can be considered in those with a PET PR. But this shows that the CAR T cells can also be saved for future lines of therapy. So what are some of the options for patients who relapsed after CAR T cells or an auto transplant? One of the areas that's been under active investigation are bispecific antibodies. So blinatumomab, you may be familiar with, which is approved in ALL, is an example of a bispecific antibody. One portion of the antibody is to a protein on the cancer cell surface, and the other is to a T-cell receptor or a T-cell protein. So the many of the ones that are being studied in lymphoma are CD20 tied to CD3, pulling the T-cells to the CD20 positive malignant B cells. The benefits of these types of therapies are most of them are done predominantly as an outpatient, sometimes requiring inpatient monitoring just in the very first weeks of the therapy. Some are even done now with subcutaneous dosing, and the toxicities have been pretty reasonable and primarily surrounding immune-mediated events. So there are 4 bispecific antibodies that are CD3, CD20 that I'd like to highlight: glofitamab, mosunetuzumab, odronextamab, and epicortamab. The first 3 have all been done as IV therapies and trying to mitigate against the risk of cytokine release syndrome or immune-mediated adverse events. What they've done is they've done step-up dosing or split dosing to fractionate the dose over time or to allow patients to kind of quote unquote get used to the therapy initially. And that seems to have decreased the rate of cytokine release syndrome and certainly severe cytokine release syndrome. Many of these studies are currently ongoing still, and so these are initial results, and we look forward to the longer term results. So in diffuse large B-cell lymphoma, these therapies universally have had overall response rate between 35 and 70%, which is pretty remarkable as these patients often had refractory disease or had been multiply pretreated. About a 20 to 55% of patients achieve a complete remission to this therapy, and these include patients who had undergone CAR T cells antecedent to this. The median duration of remission on any of these studies has not been reached, although the follow-up has been relatively short. And cytokine release syndrome has been seen in most patients, although grade 3 or 4 cytokine release syndrome has been limited. Some of these drugs are being given by IV and then are being also studied as subcutaneous dosing, and epicortamab is the first to report subcutaneous dosing. So we find this very interesting and exciting in diffuse large B-cell lymphoma as a new therapeutic potential option that we hope will become available for our patients as standard of care as well with further study. What about bispecific antibodies and CAR T cells in indolent lymphoma? So going to the same drugs, we can see that these have also shown activity in indolent lymphoma and fairly remarkable rates. So the overall response rate has been between about 65 to 90% in this patient population. The median duration of response for most of these therapies has not been reached, although again, the median duration of follow-up has been limited on most of these studies. Mosunetuzumab, which is amongst the furthest along of these therapies, the median duration of response has still been 20.4 months. So pretty remarkable in a heavily pretreated population. Patients often had a low-grade cytokine release syndrome, which often involved just like one fever early on in the therapy within the first 48 hours. But grade 3 or 4 cytokine release syndrome was very rarely seen as well. So the advantages of bispecific antibodies is that they can be used in patients who have refractory disease, including those who are rituximab refractory. It's been shown to work as well in this population. Most of the treatments are given as an outpatient after the first couple of doses. Many of these studies have been designed to have time-limited therapy for patients. So they go through a certain number of treatments or certain number of cycles, and then they stop, which is very attractive to some of our patients who have indolent lymphomas who move from one therapy to the next and experience treatment fatigue. And studies of these agents as single agents as well as in combination with other agents are currently ongoing. And so when you're thinking about your patients, I encourage you to look for some of these studies as therapeutic options. In the world of CAR T-cells with indolent lymphoma, Dr. Jacobson and colleagues present the use of Axi-cell in indolent lymphomas. This was in the context of ZUMA-5, which was a phase 2 study in follicular lymphoma and marginal zone lymphoma of patients who had had at least 2 cycles of therapy that had to have included an anthracycline. So there were 146 patients treated with Axi-cell, and 84 patients were evaluable for efficacy with follicular lymphoma and reported. The overall response rate in follicular lymphoma was 94%, and the complete remission rate was 80%. At 12 months, 77% of patients with follicular lymphoma remained disease-free, which was fairly remarkable. This is shown in the blue Kaplan-Meier curves that were pulled from the ASH presentation. Grade 3 or higher CRS or cytokine release syndrome was fairly rarely noted. For patients who had marginal zone lymphoma, in contrast, the overall response rate was 85%, but the complete remission rate was about 60%. And at 12 months, 45% of patients remained disease-free, suggesting a higher rate of relapse with marginal zone lymphoma or less durable responses than with follicular lymphoma and similar toxicity profile. So we are very encouraged about the use of CAR T-cells, particularly in follicular lymphoma, based on the results that Dr. Jacobson had been able to share. And I think the main questions are, how is the toxicity to CAR T-cells and bispecific antibodies, how they will compare to other standard of care options. As patients have more and more options, the decisions for clinical decision-making fortunately become a little bit more challenging because we have more options to pick from. Some of these other options include PI3 kinase inhibitors, lenalidomide-based combinations, CD19 antibody treatments, including antibody drug conjugates, chemotherapy approaches, which have been part of the standard for many years, as well as drugs that activate the macrophage activating system or block the do not eat me system, think drugs like magrolimab. And so how the duration of response to these therapies as well as their toxicity will be critical to help patients decide which therapy to pursue next. So now moving on to relapsed refractory Hodgkin lymphoma. The landscape for relapsed refractory Hodgkin lymphoma remains quite broad. So patients can get brentuximab, nivolumab, and pembrolizumab, which are all FDA approved for patients who have relapsed post-therapy and after their initial therapy. And they're often used as a bridge to transplant for curative intent. Additionally, patients often receive combination chemotherapy for curative intent to be followed by an autologous stem cell transplant. More novel regimens in the relapse setting, including those combined with brentuximab, seem to have a higher rate of complete remission in the 60 to 70% range. We know that brentuximab and nivolumab likely work better together than by themselves. These highlight many studies that have been done either in children and adolescents with an overall response rate of 80% to the combination, a study in older patients unable to get anthracyclines where the response rate to the combination is 91% with 65% CRs, as well as patients who receive BV-Nivo or BV-Ipi-Nivo in the relapsed refractory setting, where we also see response rates in the 90 to 95% range. And combination strategies are likely going to be better for curative intent approaches and are currently being explored as maintenance options after an autologous transplant in patients who are particularly high risk. Allison Moskowitz and colleagues shared the results of a BV-free option for relapsed refractory Hodgkin lymphoma. Considering that more and more patients are getting brentuximab in their first-line setting, this study had showed that pembrolizumab plus GVD in 39 patients had a 95% complete remission rate by PET, including 41% of patients who had been refractory to their initial therapy. And now they're also studying pembro GVD followed by pembro maintenance for patients who do not seek an autologous stem cell transplant. We look forward to those results. Very briefly to talk about relapsed refractory T-cell lymphomas and the updates in this space. Peripheral T-cell lymphomas are a rare subset of non-Hodgkin's lymphomas that tend to have limited survival compared to other forms of non-Hodgkin's lymphoma. And the overall survival and progression-free survival are very similar. Most forms of peripheral T-cell lymphoma only have a 20% survival at 5 years. And the exception of this is anaplastic large cell lymphoma ALK positive that tends to be more chemosensitive. Our paradigm for treatment is often giving combination chemotherapy followed by a PET to assess response, additional combination CHOP-based chemotherapy, and consolidation with an autologous transplant, which seems to improve the progression-free survival by about 20%. There have been multiple attempts to improve on this. The most notable has been brentuximab vedotin, CHP, for patients who have CD30 positive peripheral T-cell lymphomas. But there have been some other attempts to look to improve the outcomes as well, many of which have not resulted in a lot of change. One important negative study was a study of romidepsin CHOP versus CHOP, which was a randomized phase 3 study by the LISA group in 421 patients with peripheral T-cell lymphoma. And in here, you can see that the addition of romidepsin to CHOP-based therapy did not result in improvement in progression-free survival and overall survival, although there was a signal of improvement specifically in angioimmunoblastic T-cell lymphoma, where we think that patients may be more sensitive to romidepsin-based therapy. The addition of romidepsin seemed to have added to treatment delays, so we think that that may have had something to do with the results of this study. Azacitidine plus CHOP was studied in specifically in angioimmunoblastic T-cell lymphoma or T follicular helper peripheral T-cell lymphomas. And in this study of 20 patients published by Jia Ruan, 85% of patients achieved a complete remission, and including 75% who achieved a complete remission. And so we look forward to more with this study in this upcoming US intergroup study, where patients will be randomized to CHOP or CHOEP chemotherapy, a oral azacitidine or CC486 plus CHOP or CHOEP, or Duvelisib plus CHOP or CHOEP. And this study is anticipated to open in June, and we look forward to your participation. There have been multiple therapies for relapsed refractory T-cell lymphomas, and most of these only work, unfortunately, in 20 to 30% of patients with meager durations of remission. For patients who have relapsed refractory disease, their median progression-free survival is only 9.6 months. And this year at ASH, we were able to present updated data to show that patients who are able to achieve get an allogeneic transplant for peripheral T-cell lymphomas can have good results. So at 5 years, about 50% of patients are alive if they're able to achieve a remission sufficient for an allotransplant, and of course be candidates for an allotransplant, including having a donor. So we think this is an important thing to consider for patients who have peripheral T-cell lymphoma and are transplant eligible. The study PRIMO was also highlighted at ASH this past year. This was a study of Duvelisib, an oral PI3 kinase inhibitor in relapsed refractory T-cell lymphomas. In this study, we saw that at the the dose that was taken forward for the expansion, the response rate was about 55% to Duvelisib as a single agent, which proves to be favorable compared to historical controls of drugs that are approved that all have response rates of 25 to 30%. This study is now completed accrual, and we look forward to these updated results in the near future. There have been multiple therapies that continue to be investigated in peripheral T-cell lymphomas. The use of PI3 kinase inhibitors in combination with other drugs like romidepsin seem to be promising as well. ITK inhibitors, inhibitors of ICOS, an antibody that's on T follicular helper cells, as well as immunotherapy-based combinations are of interest. Medicines that help to modulate the chromatin expression, or including EZH2 inhibition, also is of interest, as are CD47 strategies that we highlighted earlier. So the conclusion in peripheral T-cell lymphomas is that we still need better upfront therapies, and relapsed refractory disease can be improved with consolidation with an allogeneic transplant and better relapse therapies. With that, I thank you for your attention. Feel free to contact me, and I thank our patients and my funding sources, as well as the Siteman Cancer Center. Thank you.